I was so freaked out, I forgot to take a screenshot to memorialize the occasion. I said, this is really amazing. I mean, I understand the technology, but it's still like, wow, you can really do this?
Fantastic.
Yeah, yeah.
So Barry, so
Yes,
I think you can get started. I know still people are going to log in. This is the last week of the uh, educational year, so we have a lot of people who are departed. So let's get started because you will take 1 minute to talk about the scope of practice, and then we can get started with the presentation. So we have enough time at the end for
right.
questions.
I'd like to get through this so we have some time at the end for people to ask questions.
Yes. So we
Yes,
can get started.
okay. So I'm ready now to start talking.
Yes, please go ahead.
Good morning, Cedars Sinai trainees and staff. A quick a quick note about my scope of practice. I'm a board certified anesthesiologist in clinical practice more than 41 years. The last 26 years have been in office-based anesthesia for elective cosmetic surgery. And these are all ASA 1 and 2 patients, spontaneously breathing and minimally invasive. Now, my opioid-free career started in 1990 with a tragic fentanyl death in Newport Beach. And the fellow that I developed this technique for said, go ahead, you can use any drugs you like, but no opioids. So from the get-go in 1992, all of the cases I did, to say more than 6,000 cases, were opioid-free. Okay, so we had the title. The title is pretty provocative. Thank you very much. Postoperative pain is a function of intraoperative pain. My disclaimer is I have no financial interest and none of the images you see have been photoshopped. Conventional wisdom has always said, don't give a microphone to an old guy because he's got too many years to talk about. Okay, well, I guess I'm not going to get my filming done here. That was Dodger pitcher great Sandy Koufax. So here I am in 1992. The big thing I'm concerned about is I'm using ketamine instead of fentanyl, and everybody knew at the time that ketamine causes hallucinations, hypertension, and tachycardia. And I'm trying to explore the idea that hypnotic doses of propofol work just as well as doses of benzodiazepines to prevent hallucinations. And I know that the first patient who wakes up hallucinating will be the end of the experiment. So the first 25 cases go by, and lo and behold, not a single patient has hallucinations. Interestingly enough, none of them also have postoperative pain or nausea and vomiting, the two most common problems after surgery. I do another 50 cases, and the same thing holds, and I'm very excited. I get my first publication about hypnotic doses of propofol block ketamine induced hallucinations. Unfortunately, it's in the plastic surgery literature, and nobody is actually reading that. And if they read it, they wouldn't believe it. The next publication was my first 50 cases. And the biggest mistake I made was to emulate Chuck Vinnick's diazepam-ketamine. He was not mixing the two drugs, and neither was I. But I didn't know anything better about publishing and writing. And so I stuck this hyphen in there, much to my regret. I want you to focus on this image of the martini and the olive. This is what I do. It is not ketofol, which the only other person who wrote about ketamine with propofol, Dr. Guit in 1991. So ketamine, the 50 milligrams of ketamine is the perfect olive to the propofol martini. There are lots of pathways to opioid-free anesthesia. I have an extremely simple approach. My friend, Dr. Charlie Laredo, anesthesiologist at University of Chicago, said that which anesthetize least anesthetize best. You see the two pictures here, the multimodal Queen Anne Victorian, very ornate and challenging, and the very clean and simple, I don't know why this keeps advancing, Bauhaus, less is more. I wrote this article in Outpatient Surgery Magazine, Minimally Invasive Anesthesia for Minimally Invasive Surgery in 2004. Much to my surprise, the anesthesia service at Sweden's Karolinska Institute posted on their website, and I asked one of my friends in academic medicine, why would they do such a thing with a trade journal article? And the response was, apparently the Swedes understand not everything useful is found in level 1 RCTs. Moving right along, I want to introduce you to the 9 words I hope history will be kind enough to remember me. You've all heard of Virchow's triad and Cushing's triad. Let me introduce you to Friedberg's triad: measure the brain, preempt the pain, emetic drugs abstain. This is my simplified pathway to opioid-free anesthesia and better outcomes. You say, well, that's a pretty big boast, Dr. Friedberg. What are you talking about outcomes? Well, in the 20 years of brain monitoring, more than 4,000 AFL-defined high-risk patients, that's non-smoking females with histories of PONV or motion sickness, having a metagenic surgery like cosmetic surgery. These are all outpatients, and I worked with over 100 different surgeons. The pathway, very simple: incremental propofol, then 50 milligrams of ketamine, then subcutaneous tumescent analgesia. I will be talking about tumescence in a little bit later in the talk. Remember that pain and post-op nausea and vomiting are the two most common reasons for unexpected admission after day surgery. None of these patients, not a single one, was admitted for either problem. The other interesting point for the experience was an unprecedented 0.6% PONV rate was posted without the use of antiemetics. Consensus guidelines would have us add one antiemetic or antiemetic maneuver for every one of those AFL-defined risk factors. There were no opioid addicts or overdose deaths. There was no awareness or recall, despite the fact no midazolam was used in this period of time. The overwhelming majority of patients were discharged home in an hour without requiring professional aftercare services, and there were no similar outcomes reported by enhanced recovery after anesthesia, the American Society for Advanced Enhanced Recovery, or the postoperative surgical home. Now we want to talk a little bit about the value of direct measurement. I think thanks to Dr. Wender's direction, Cedars has led the nation in the use of direct brain monitoring, so I don't need to belabor this point too much. You're giving average doses, you're getting 80% direct measurement, you get 100%. A little word about confirmation bias. In the era that I first started, this publication came out in 2000. I was trying very hard to reduce the amount of propofol used. Prior to the brain monitor, I was using 320 cc ampules an hour, and with clonidine pre-medication and the bispectral index monitoring, reduced it to 2. Well, that was fine and dandy while propofol was expensive, proprietary. Once it became generic, I decided to drop the clonidine because the occasional postural hypotension, and lo and behold, the 2 ampules, 220 c ampules rate remained. So while I thought I was doing something really clever with the clonidine, I really wasn't. So you have a cortical monitor choice here. In 1997, of course, there were no choices. The BIS was the first. There's at least Sedline and Entropy and probably several others I'm not aware of, but there are no papers showing any superiority to the BIS. Lord Kelvin's favorite quote of mine: if you cannot measure it, you cannot improve it. And here we are with BIS levels. You all know these numbers. These particular numbers come from my textbook, Anesthesia and Cosmetic Surgery. And before you completely pigeonhole my work, remember that Chapter 7 was written by the US military, implications for military medicine and mass casualty anesthesia. This is from 2009, and you can see the lower trace is the real-time electromyogram signal. It took me years to actually look over to the right-hand side to see that there was a second measure for the EMG, because I was really focused on this activity here. All right, moving right along. With measurement, I was able to see a 100-fold variation in propofol requirement to achieve the same numerical level of moderate to deep sedation. Most patients are 25 to 50 micrograms per kilogram per minute. The really fragile patient is down at an unbelievable 2 mics per kilo per minute, and the really resistant patient as high as 200 mics per kilo per minute. Let's see. This is the patient, the fragile patient, and I promise you again, there is no Photoshop here, but I will agree it does inspire cognitive dissonance. Let's see if we can turn that up. There she is. She's 60 kilograms and she's floating along at 2 micrograms per kilo, and I can't barely even get her up to 60 on the BIS. In the lower trace, you see I was actually using end-tidal CO2 at this point in my career. When you see the abdominoplasty clip, you'll realize that this was before end-tidal CO2. And it's still, this case went on for about 4 hours. When we turned off the propofol, she woke up like we were flipping a light switch. Okay. All right. So why is it that people don't use the BIS more often? The trace over here, the 43 and the trend, we trend everything on our screen from left cardiogram, blood pressure, pulse ox, end-tidal CO2, and those are real-time signals. Unfortunately, this signal is delayed by 15 to 30 seconds. So it's about as useful as trying to drive your car with a rearview mirror. Once you set up the secondary trend on the freestanding units, now you're looking through the windshield and you know what's about to happen to the patient. The EMG spike is incipient arousal, or in other words, the patient saying, Dr. Friedberg, I'm about to wake up. Would you please give me some more propofol so I don't wake up? Now, the incremental induction outcomes deliver you a patent airway with spontaneous ventilation because you preserve the muscle tone. These are all muscles involved. And I want you to try, when you decide to give this a shot, to resist the compulsion to instrument an airway, a patent airway with this minimal approach. So for elective cases, the value of propofol induction is you never have the difficult airway. It's less stress on you and less stress on the patient. Minimal airway trespass means in that 20-year cycle, I only managed to use as much as 10% LMA, never had to intubate anybody in my entire 26-year office career. What causes the difficult airway is the bolus airway we so blithely give. We'll be talking about 50 mic per kilogram sequential boluses. The average anesthesia person is giving 1,000 to 2,000 micrograms per kilogram as a bolus. It allows you to rapidly identify those outliers I just discussed with you. So cosmetic surgery patients are highly complaint prone. They don't like anything that bothers them, and a sore throat is one of the things you get when you routinely instrument the airway. So over that 26-year period, more than 6,000 patients, two-thirds of which didn't require airway instrumentation. A third were in the right tudectomy or facelift position, chin up, laterally rotated. Another third in the same position, but an IV bag under the shoulders to increase the force of extension on the genioglossus. Another third in nasal airway, about 10% LMA. And the only time I routinely use the LMA is for rhinoplasty. Again, no endotracheal intubation in 26 years. Here is a clip that's been seen over 200,000 times on YouTube. These are for elective cases. We're not talking about ruptured aneurysms or prolapsed umbilical cords. With a 50 microgram bolus sequentially, you don't see burning, so you don't have to give anything up hand. And I remind you of your first day's lecture when they said primum non nocere, or first do no harm.
Here is that the red area EMG will start to decrease before the yellow, the Bismuth. Here's Dr. Link.
I didn't realize you're so tall.
Yeah, especially when I'm standing.
I'm interested, right? I'm going right now. Feel it.
It feels pleasant.
It's pleasant. It's like my ideal way to die, but I mean,
Well, we tend not to do that.
I'm like 106, you know.
Yeah.
All my dogs by my side though.
Mhm.
What can they have? Right. I'm a daughter.
So this young lady is a nice young lady.
Will I be twitching?
No, no twitching.
I might be gassy because I didn't eat, but
Yeah, that's okay. We don't charge extra for gases.
I'm feeling a little drunk.
It's pleasant though, isn't it?
It's a drunk feeling. I
So
might say, I'm sorry, staff, but I might say shit that I don't.
you would see.
Just don't worry, you know, I haven't had food since 10, so.
Fortunately, this little video doesn't have audio in it. It's just the video. So
Please don't mind my dry mouth.
it's okay.
Every time my son touches the
Isn't that nice?
pump, she's getting
I
50
think
mic
everybody likes Dr. Creeper.
And when I get home,
Yes,
how to immediate,
immediately.
but I basically for it.
Mhm.
If I wake up and it's very anesthesia, this,
Mhm.
I can eat, right?
Yep.
I mean,
Okay.
chances.
Mhm.
I mean,
probably pretty hard to see, but the real-time lower trend is going down before the biz.
Okay. Make sure to get that.
I got both. I got her and I got Biz in the frame.
Perfect. That's great. You can stop then.
So the concept of preemptive analgesia is that the brain cannot process information it does not receive. The red line is what I call the midbrain spinal anesthetic. This is what happens with the 50 milligrams of ketamine 2 to 3 minutes before stimulation. Nothing gets to the cortex. And this was during the time that I did not use a pump and I did not have the biz. Okay, let's try going forward. So, Dr. Freeberg, if you don't use opioids during surgery, we give opioids so that we're reducing post-op pain. And this meta-analysis that came out in 2019 was a perfect complement to my work. They looked at 23 studies and 1,304 patients, and compared to opioid free anesthesia, giving anesthesia with opioids fails to reduce post-operative pain, but increases post-op nausea and vomiting, the number one things patients want to avoid. Well, if you're not going to give opioids, how about deeper anesthesia, Dr. Friedberg? Lichtner and colleagues showed us that nociceptive activation of the spinal cord and brain persists even during deep general anesthesia, much less in sedation. So ketamine is our most unique drug. It is, as you all know, it's an NMDA receptor agonist. You may not know it's second generation phencyclidine phosphate, PCP, or the 1959 trade name Serenil from Park Davis. Ketamine does not produce hallucinations if you have a stable CNS propofol level in the way I just showed you for the induction. The 50 milligrams, the nifty 50, I like things that rhyme because they're easy to remember. The clinical evidence for the dissociative effect is the patient doesn't move. Or as they said to me at Stanford in 1975, it's the mineralizing drug. I said, well, what do you mean mineralizing? He said, yeah, when you give it, they lay there like a stone. I said, I guess that's kind of humor, right? Okay, so evidence, NMDA receptor saturation produces opioid-free preemptive analgesia, and the same 50 milligram dose produces the same 10 to 20 minutes of immobility in patients weighing as little as 30 kilograms all the way to the picture, and the patient pictured here, 146 kilograms, patients as young as 7 and as old as 94. So my conclusion is that the number of NMDA receptors does not vary with weight or age. So what's the objective reproducible evidence of NMDA saturation? The arrow is pointing to no response when the patient receives stimulation, and that stimulation can either be incision, skin incision, trocar punctures, or in my world, multiple local anesthetic injections. Okay, so here we have a low pain threshold patient. That would be me. This is my last year's outpatient total hip replacement. And what's pictured here is the BIS plug-in module. I got a mepivacaine spinal. I don't know why it keeps going forward like that. I guess it's telling me I've run out of time. And BIS EMG monitored propofol, 50 milligrams ketamine, 2 to 3 minutes pre-incision. The BIS is 72, as you can see, and the EMG is 26. There is no response at 8:38 with skin incision. I had no opioid rescue and recovery room, and I was home by 4 o'clock that day. I took no post-op opioids for 10 days, 12 days post-operatively, was only taking 1,000 milligrams of acetaminophen with 800 milligrams of ibuprofen religiously every 8 hours. So what's this deal about arousal and nociception? When you touch the hot stove, there's a reflex withdrawal followed by the ouch, not the other way around. So EMG spikes are indicative of incipient arousal, and the conclusion is to deal with the spike and you have no arousal and thus no nociception. What's the objective evidence of adequate analgesia and sedation? I don't know how many of you have had the experience, but my plastic surgeons and cosmetic surgeons get very twitchy and get very upset when they see any patient movement because they believe that vasoconstriction equals analgesia. But here I'm showing you the conditions under which you can assure the surgeon that the patient is asleep and amnestic, and movement without real-time EMG spike is non-purposeful and will readily respond to increased local anesthetic in the immediate area of sedation. So this is a major problem in sedation, and now you have objective evidence with which you can work with the surgeon to eliminate the whole too light needs more local discussion. When do I give more ketamine? Well, when I looked at 1,000 cases in an informal survey, 80% were done with 1 or 2 50 milligram doses. and those include cases up to 4 and 6 hours. Virgin field injections demand a second 50 milligram. In the early days, the surgeons didn't want to inject both sides of the face. And as years went by, I convinced them to go ahead and inject both sides, and it was okay. If there's persistent non-purposeful movement after 2 additional local anesthetic injections, I'll also give the additional ketamine. There we go. You want to avoid more than 200 milligrams of ketamine because you're going to have prolonged emergence, and definitely no ketamine in the last 20 minutes. Here's where you and I get together because you're giving a fair number of cases, more and more cases with ultrasound-guided regional anesthesia, and all of my cases were done with subcutaneous tumescent anesthesia. As you see, both medically indicating cosmetic cases are under spontaneous ventilation and EMG activity persists, and we're both going through the skin. Jeffrey Klein, who developed tumescent anesthesia, talks about it as regional anesthesia, but he's using the word a little differently than you and I use it. So tumescent anesthesia is the term cosmetic surgeons use. The plastic surgeons prefer to use the term wetting solutions. And much to my surprise, when I left the hospital practice in 1991 or so, not all cosmetic cases are performed by plastic surgeons. The tumescent solution is prepared simply with 500 milligrams of plain lidocaine, a milligram of epinephrine, and 1,000 cc's of lactated ringers or normal saline. You can see the liposuction guidelines, alternative uses. This is really interesting. Okay, so that's what we have there. A quick warning, there's ketamine-associated laryngospasm. It is very rare, but it involves total cord closure, and you won't hear any crowing noise. The only prodrome or warning you're going to get is a cough or a sneeze, and you should respond with a milligram per pound of lidocaine, not a milligram per kilogram. So why are we so delinquent about patient's number one concern? Well, the reality is it doesn't happen on our operating table. It becomes somebody else's problem. Now, when Alex Macario did the twin scientifically validated surveys in 1999, anesthesiologists, of course, chose number one, pain. That's what we think about we're doing in the operating room and why the title of the talk is so provocative, because that was the OMG WTF moment. It's like, well, wait a second here. I'm not giving opioids and patients are not having pain and not sick to their stomach. There must be some relationship here. And the only reason people are having pain after surgery is they must be having pain during surgery. Patients chose emesis, gagging on the endotracheal tube, and nausea before pain. And the reason is when you give surgical consent, you're giving some surgeon permission to stick you with a knife. And everybody who's been cut with a knife knows it hurts, but doesn't necessarily involve nausea and vomiting. Okay, the nasty thing about opioids. The nasty thing we all know about post-op nausea and vomiting, respiratory depression, obstruction, blah, 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 sedation, prolonged emergence. These are all things, these are not news to anybody in this audience. You've all heard this story before. What may be news is Kessler's study that looked at Orati's and their impact on clinical and economic outcomes, looking at 55% increased length of stay, 47% higher cost, 36% increased 30-day readmission rate, which is a ding for Medicare and such, and 3.4 times higher mortality risk. That ought to give you some pause about giving opioids as a routine, which is what I did for the first 15 years of my practice. This is a 2009 abdominoplasty in a ASA class 1 50-year-old Hispanic female. This is well before end-tidal CO2 was required. She received incremental propofol induction and maintenance, as we described, 150 milligram dose of ketamine and 2.5 liters of tumescent analgesia injected simply into the subcutaneous space. There was no injection in the rectus sheath. And what you see there, the purple outline, is the medial edges of the rectus muscle sheath, not the rectus muscle. Many of us have the impression that abdominoplasty involves sewing the rectus muscles together. It does not. It is the sheath. So this is not a tap block. This is just subcutaneous lidocaine. And let's roll this.
This afternoon.
Like that color? I love it. Is it HD one? Yep.
See, her orbicularosaurus and temporalis and masseter are not doing their job. And with that minimal airway intervention, her sat comes back up. And she only has a single respiratory depressant, the propofol, titrated to both the pulse ox and the cortical response. And I want you to pay attention to the trace here. You can see every time the spike goes up, she's going to get more propofol, more propofol. She continues to breathe spontaneously, but in the meantime, the time delayed BIS number stays within the selected range. So what we have here is a virtual video game. And instead of responding to heart rate and blood pressure changes like I was trained to do in the 70s, I realize that's ancient history, but that's okay. This engages your mind in the case in a manner that there's no other way to describe it than the virtual video game. This is compelling interest because this is what you do. 100 to 200 mics per kilo boluses repeated over and over again, avoiding apnea, but getting the BIS to come back to baseline. Now, it's a little more challenging with the plug-in module because all you have is a number. But anytime you see an abrupt change in that number, you can respond in the same way that I would respond to these EMG spikes. I think we're there. There we go. And this is the same patient less than 5 minutes after we turn off.
Okay, Lily, what'd you think about the experience? Was it pretty good?
Yeah.
Did you remember anything? You've been asleep for 4 hours.
Oh,
Don't remember a thing. No bad dreams.
no.
Wonderful. So that was really a good experience, then, huh?
Yeah.
You like Dr. Lynn, don't you?
Yeah.
He's the best. And
Yes.
Anais held your hand, and I held your other hand, and you had a good snooze.
Oh,
And no dreams.
no.
Fantastic. All right, well, speedy recovery. Okay, Lily.
So how do I do it? Because ketamine increases secretions, I always give glycopyrrolate, and I prefer glycopyrrolate over atropine because atropine causes more heart rate increases. And invariably what happens when the plastic or cosmetic surgeon injects the local with the lidocaine with the epinephrine is you see an increase in heart rate. And I don't want to think about where's the dantrolene that day. I just prefer a nice calm day. So glycopyrrolate instead of atropine. You've seen how I incrementally induce the patient and maintain them at BIS range between 60 and 75 with baseline EMG, or if you only have a plug-in, keeping it around wherever it started. 26 was in the example I showed you in my own hip case. Before the injection of the local anesthetic, before the incision or trocar punctures, you give the nifty 50 milligrams of ketamine. And the reason you need a couple of minutes is you need more than one circulation time to completely saturate those NMDA receptors. And then all of my cases, aside from rhinoplasties and blepharoplasties, got subcutaneous tumescent injection. And for the abdominoplasties, we would splash 50 cc's of bupivacaine in the field. You don't have to inject it because it binds quickly to protein. Many times they would wait till the case was closed and inject 25 cc's up of each drain on either side. So that's kind of the basic, not very glamorous, but very effective technique. Now, the other confirmation bias story I want to share with you is rofecoxib. When rofecoxib came out, Vioxx, we were all excited. We thought surely pre-treating the patients with this will give us a better outcome. And we were ecstatic. Boy, we thought this was the greatest thing since sliced bread. And then they took Vioxx off the market. Nothing changed. So all that good effect was a confirmation bias again. We thought we were doing something wonderful, and it turned out we really weren't. It was just, we believed that that was the case. Let's see what else we have here. So Dr. Freeberg, cosmetic cases are nice, but let's get real. What about, real life surgery? And we've had two studies, an open cholecystectomy. I don't know if anybody's ever seen an open cholecystectomy or an open hysterectomy, but we used to do those in the old days. Pretty invasive, pretty irritating stuff. And both of these studies received pre-incision ketamine, one at 1 milligram per kilogram, the other at 0.5 milligram per kilogram. I will tell you the story about ketamine again. When I started, I used Chuck Vinnick's 75 milligrams because that's what he was using, and what did I know? And in the first couple of cases, a couple of patients woke up with horizontal nystagmus. And so I said, well, maybe if 75 is too much, let's try 50. And the reason I was using those increments is that ketamine comes as 50 milligrams per cc. So it's pretty easy to drop a cc and a half for 75 and 1 cc for 50 milligrams. And so being the curious sort of fellow in the early part of my practice, I said, well, if 50 is good, maybe I only need 25. And so I tried 25 for a period of time, and it worked pretty well. I had immobile patients 4 to 5 times. But what happened, I had to stop the surgeon from injecting to give the additional 25 milligrams. And it turns out that as long as you have the patient asleep and at a BIS below 75, there's no downside. You're not going to see hypertension, tachycardia, hallucinations with 50 milligrams. So in the office-based setting, keeping it simple is a real advantage. And the idea of coming in and setting up 3 infusion pumps for dexmedetomidine and lidocaine and all that other stuff that other people are using might be wonderful, but it's very distressing to the surgeon. They're wondering, what do you need all that stuff for? You know, we know that we can do all these cases under straight local if we're gentle with the tissue and good with the local. So why are you making things more complicated? At any rate, the radical concepts I want to leave you with: ketamine does not cause hallucinations. Please, I know this is a teaching. It's only correct if ketamine is the only drug you're giving. Who does that? I haven't been doing that for almost 30 years, and I've been publishing and lecturing about it. And that postoperative pain is a real function of intraoperative pain. Pretty radical idea, since we think the main reason we're in the operating room, and that's what I was taught, I'm sure you were taught, we're there to prevent the patient from experiencing pain during surgery. So I'm really interested to hear what people have to say afterwards. I'd like you to remember that using opioids doesn't reduce postoperative pain, but it does increase postoperative nausea and vomiting, which is patients' #1 concern. It may not be as big an issue with medically indicated patients, but I can assure you that in the elective cosmetic practice, it is a real disaster. The other thing, of course, that can happen is you can tear the sutures in the abdominoplasty, you can create hematomas underneath skin flaps and the facelifts, and that's a real nightmare for the surgeon as well. And the last thought I want to leave you with is the NMDA saturating dose of ketamine is independent of body weight and age. Keeping it simple, 50 milligrams does the trick in patients as low as 30 kilograms and as high as 146 kilograms, and at ages 7 to 94. Those are my experiences. We can argue all you like, but that's what I've done for 26 years. All right, I want to leave you with the 9 words that I hope history will remember me by: measure the brain, preempt the pain, emetic drugs abstain. And I'll be happy to take questions at this time. Well, that was 30 minutes. I thought I was going to not get there. Okay. Hello?
Hi, Barry. Thank you very much for the presentation. I had a question for you.
Good.
Um,
Hopefully I have an
so
answer
it's-
for you.
Yeah, most probably you have. So
Okay.
you talk that is not weight dependent. So the 50 looks like the magic number that would be
It is.
used for all
And there's
weights.
no other drug that we use that way.
Right.
But
So
that has
that
to
you
accept
need
it.
to
Yeah,
saturate the NMDA receptor. What about the duration of surgery? So would you adjust the dose
right.
if you have a 1 hour procedure or half an hour procedure, you would use it? Because in your presentation, you mentioned that don't use 20 minutes prior to the end of the procedure. So I'm just wondering if you adjust your dose based on the duration of surgery.
Good question. Excellent question. First of all, I don't use, none of my cases were less than 20 minutes. So the 20-minute minimum is a good point. My average case ran 2.5 hours, and a lot of them run 4 to 6 hours. And the answer to the question is no, because the reason you don't give more ketamine is the deception that the ketamine created with the injection of the local is duplicated by the deception of the local analgesia, which is the whole point of making sure you have adequate local. If you have the adequate local, there's no reason to keep giving more ketamine. A lot of people out there doing opioid free anesthesia give, including my dear friend Professor Moulier of Belgium, they give a continuous ketamine infusion during the case. And I'm saying, well, clearly they're doing that because they don't have adequate analgesia. And it's very hard to believe that the superficial injection of the subcutaneous tissue is going to be adequate for the abdominoplasty in particular. That's the most dramatic case we do. And the reason I call it minimally invasive is that it's extraperitoneal. So as long as you've deceived the brain with the initial injection, and this is really the problem. In the old days, they taught us that if heart rate and blood pressure don't increase with skin injection, we've done the job, everything's good. And now I can tell you, as long as you don't have EMG activity with skin incision, everything is good, because the brain doesn't know the body's been invaded. And without that knowledge, or I should say with that knowledge, the internal pain fibers go on high alert. So it's one of the great magic tricks of life.
Right. So basically, you would not adjust the dose, the 50 milligram, in shorter procedures, means as far as you have almost 1 hour.
No, it's
Okay,
not a problem.
good. And Barry, what's the duration of, because you use ketamine to saturate the NMDA receptors, and you said in your presentation that you would redose it after 4 hours. So that's the duration that you think? Is that correct? Did I understand it right? So
No,
if you have to redose, if for
wonderful.
example,
Yeah.
if you have an
She's like
8-hour
slowly
procedure, if you have to redose, at what point you would redose the 50 milligram?
let me go back here a second and see if we can find that. These are my indications for redosing. In other words, in the case where the surgeon is only
Totally.
It's so exciting to see you.
They were playing together.
Kat, I'm sorry, we need to mute people, please.
That's going to cover first.
okay. The indications for more ketamine is not the length of the case. It has to do, in my world, if you have a virgin field. In other words, if the surgeon on a facelift only wants to inject one side, and now he's done the dissection, he's ready to inject the other side, you can't inject the other side without sending the alarm to the patient. So you need that 50 milligrams on board so he can inject the second side. Does that make any sense? I don't.
Yes.
I don't think I ever said anything about 4 hours and more ketamine.
Right. So basically, if your case is 8 hours, you would not redose. So I'm just wondering what's the principle behind that? Because if you saturated the NMDAs with your first 50, why do you need to redose if he's doing the incision on the other side?
Well,
If the
because
NMDAs are saturated, why do you need the second dose on the second side?
because if you don't, the patient's going to respond. Even though you, in other words, the length of saturation time is only 10 to 20 minutes. Okay. Once you're outside that envelope, if you inject a virgin field, you're going to have a squirming patient. Your EMG is going to go up and down, and it's not going to be pretty. The idea with the injection is you want the patient to lie still, right?
Okay, so that's really for the incision. That's what you're calling as first insult. That's the
Right.
reason you're using it. Okay, good. Thank you.
Okay. Next question.
If no other question, I have one more question for you regarding clonidine. I know you just touched base a little bit on it at the
Right.
beginning.
Right.
What type of dose did you use? And you mentioned something about hypertension. That's what you had to deal with. What was
Right.
the percent of hypertension that you saw in the clonidine cases? The dose that you would use?
For patients weighing between 95 and 175 pounds, I gave 0.2 milligram of clonidine, trying to achieve a 2.5 to 5 microgram per kilogram blood level. Excuse me. And the incidence of postural hypotension was very small, but when it happened, it was irritating. And so the whole point I was thinking I was doing with the clonidine, excuse me, was creating a propofol sparing effect. Because in those days, propofol was $12 to $15 a bottle, and I'm 20 cc bottle, and I'm using an average of 3 bottles an hour. So I thought that the clonidine plus the BIS monitoring was giving me that 30% statistically significant reduction in propofol use. And then once the propofol became generic, it wasn't nearly as pressing an issue to try to spare the amount of propofol. And lo and behold, I still was using the same 2 bottles of 20 cc's an hour on average without the clonidine. So it wasn't that it was a big problem, but you have to remember in office anesthesia, we don't have a lot of people. You know, there's an admitting nurse, a scrub nurse, a surgeon, and me, and rarely there was a circulating nurse. I mean, especially in the days in the 90s before office regulation. I don't know how much has changed in the 20s, but back then it was, you know, bare bones. And somebody who was getting hypotensive when you want to get them in the car was a real annoyance. And so I said, if we're not going to save any money, why are we doing this? And so great surprise, you know, here you think you're doing something great. You think you're such a clever person, and it turns out not so clever after all. That's called confirmation bias. Just
Yeah.
like the same story I told with the rofecoxib. And so my experience with the clonidine gives me the same feeling about dexmedetomidine. And when I was working, it was expensive. It was tedious to dose. I understand things have worked out. It's much cheaper now. It's easier to dose, but it's a similar issue. It seems like a good idea. And if you're a big dexmedetomidine user, I would say try 10 or so cases without it and see if you notice any difference in your outcomes. And my suspicion, based on my clonidine experience, is you're probably not going to see any difference. But once something becomes ingrained in practice, kind of like our 120 plus year history of giving opioids, very difficult to convince an anesthesiologist or a nurse anesthetist to keep their hands off the fentanyl. Don't need it.
Yeah.
It's not only don't you need it, it's counterproductive. It's not helping.
Okay. Thank you. I think Dr. Consilvio had a question in the chat.
Please.
Chris?
Oh, hey, I was just saying, can you hear me?
Yes.
I was just saying, a lot of the residents, you know, I bet you 15 years ago when you presented this, people were like saying that you're crazy, but there's probably a lot of not as many comments now because I think a lot of the current residents are saying, oh yeah, that seems like a good idea, you know, sounds great, as if it's almost the norm, and that your techniques have, you know, maybe not exactly, but have the world has caught up to them. So congrats.
Thank you. Thank you. It's not easy. Actually, I take you back to 1993 when I did my first 50 case poster case demonstration at Samba. The criticism was excoriating. Here I figured I'm offering a solution, not the solution, but a solution to pain and post-op nausea and vomiting, and people are acting like I'm trying to give them HIV/AIDS. I mean, it's really hard to imagine 15 years ago, 30 years ago, now the ketamine has become more popular for refractory depression and chronic pain, and it's not quite as scary. But back then, the drug was lumped with Rohypnol and GHB as a date rape drug. It's known as a veterinary anesthetic and is known as a rave drug. And you're right, people said, what are you, crazy? Nobody gives that drug to adult day patients. I said, well, if that's the only drug you're giving, I would agree, but it's not like I hadn't been trying for 30 years to tell people this is how you use ketamine and why it's so much better than fentanyl. When I was here in 2009, the opioid epidemic wasn't quite as big a deal. So most of my efforts in the early years were trying to convince people that ketamine is not the bad guy that you may have heard of. Yes, it does cause hypertension, tachycardia, hallucinations, increased intracranial pressure if it's the only agent you're giving. But if it's the olive in the propofol martini, it's a godsend to outcomes. Now, I'll tell you quickly about the case of Main Street Surgical Center in Orange, California. My friend Narendra Parson built this 5-room surgery center with his orthopedic surgeons across the street from St. Joseph's. And after years of talking to him, he finally agreed to use the Biz monitor with the EMG. They had freestanding ones then, and to give the nifty 50, the 50 milligrams of ketamine before the orthopods would do their thing. And they're not injecting local. So the only thing he was doing different was adding the Biz EMG and the nifty 50 milligrams of ketamine. And so what was happening is the guys to staff the other 4 rooms would come over from St. Joseph's, and they would start asking him, why do his patients look so much better than their patients? And they found out about the 50 milligrams of ketamine, and then they started using it. And it's kind of like a metastasis effect. Gradually, most of the guys in the St. Joseph's group are using the 50 milligrams. But it's a very tough sell to overcome the bias of our training. When somebody tells you this is a bad drug, it's safe, but it gives you very bad effects, it's very hard. And we've all been told that opioids are essential for all anesthetic because, after all, surgery is painful, opioids are painkillers, and therefore all surgery requires the judicious use of opioids. And that's the untold catechism that we all live with. But it turns out it's not true. It's just not true. But thank you for that support. I really appreciate it. It's nice that I've lived long enough, unlike Ignaz Semmelweis, who thought washing hands would be a better way to diminish maternal mortality. And hopefully people will remember Freeberg's triad: measure the brain, preempt the pain, emetic drugs, abstain. Thank you for your comment.
Any other questions?
Is anybody still awake?
Hi, Dr. Freeberg. My name is Henry. I have a
Hi.
question for you. I can think of no other type of operation where opioids are really essential, and that's cardiac surgery. Now, I know you take care of mainly ASA1 and ASA2 patients, but what if you were to extrapolate this technique to the really sick ASA3s and 4s, in particular patients undergoing cardiac surgery? What do you think your technique, what type of outcomes would come from this technique for cardiac surgery?
Well, I'm really glad you asked that question because I have a dear friend in Florida, Rafael Cabrales, RCABRALES at yahoo.com, who in fact has been giving cardiac anesthesia for years, opioid free. So I will post that someplace for you to reach out and contact him, but he is also using opioid free anesthesia for cardiac. The irony is that my career started at Stanford and I did 5 years of open heart anesthesia in my pre-opioid free days. How much of a believer I was in opioids is I was the one who got the hospital to include the 20 cc ampule of fentanyl in the formula so I could use that on my class 4 hearts. And so, you couldn't find a much bigger believer in opioids than yours truly. And I reached out and I found people who are actually doing opioid-free cardiac anesthesia.
Thank you.
Yes, okay.
So looks like no more question.
Here, I was so worried I wasn't going to be able to finish the material in time. I just wanted to be sure that people had a chance to talk. And, the trouble is when you've been around as long as I have, you have more stories than you can count on. And you just don't want to digress. You want to get to the material and then leave people a chance to say, well, what the heck was that all about, Dr. Friedberg? Everybody knows that, the reason we're in the operating room is to prevent pain during the case. And you're coming here telling us that we're not doing what we thought we were doing. That's a pretty provocative thing to lay out there. And I give you a great deal of credit for allowing me to present this. I don't usually have the conclusion of my work in the title of the talk, but I liked it so much. I said, I think Dr. Yamul has a good point. If you're going to stimulate interest in a talk, why not start with the most provocative statement? And that was what I realized in 1993. That was the OMG WTF moment. I said, how can it be that I've given no narcotics and nobody's Nobody looks like they've had surgery. I don't know if you remember that, the look of the woman in the abdominoplasty that I showed you, but I mean, she didn't look like she'd had 4 hours worth of surgery. She didn't look the least bit traumatized, didn't sound traumatized. It's like, how can this be? We know what patients look like after surgery, right? They look a little beaten up and they
Mhm.
not, speaking clearly. And well, I mean, most of my patients are already a 9 or 10, depending on whether they're speaking spontaneously or not. So in the
Good.
office setting, there is no recovery room and there's no dedicated recovery room nurse. So the
Right.
demand is to have that patient as awake and physiologically fit as possible at the end of surgery, whether that's a 4 or 6 hour case.
Yes. Good. Thank you very much, Barry. I really appreciate your time. And David, hold on a second. I think there was something in the chat.
Yes,
I think someone is asking for the contact.
Okay,
the contact.
I cannot see the question here. Is there an email we can reach Dr. Friedberg?
Oh, Dr. Friedberg at GoldilocksFoundation.org.
Okay, so if no other questions, thank you very much, Barry. And nice seeing you again. And I think let's continue at this point so people can make it to the operating room. Thank
Yeah,
you very
okay.
much.
I know the pressure is on to get to the operating room and start the case. So it's a little, I spoke a little more quickly than I normally would with the hope to get through the material and allow some questioning. So hopefully that worked out and you're happy. And I thank you all for the invitation, the honor of being able to speak to you, and wish you the very best.
Thank you very much.
You're welcome.
Bye.
Bye-bye now.
Thank you, Dr. Barry. If there's anything else that you need, feel free to contact me or Karen.
Okay, fantastic. You guys have a great day.
Awesome. You as well. Thank you so much, Doctor.
Sure. Happy hump day.
Thank you.
Bye-bye now.